Right, so it's my privilege to chair the first session for CCR Down Under 2025. So we're going to be talking about the ImmunoSep trial, and I'd just like to introduce, first of all, the principal investigator, chief investigator for the ImmunoSep trial, which is Evangelos Giamarellis, Professor of Internal Medicine and Infectious Diseases at the Medical School of the National and Kapodistrian University of Athens. And we're also going to have an editorial, which is going to be provided by Sarah Sasson, who is a clinical immunologist, immunopathologist, and group leader at the Kirby Institute of Infection and Immunity at the University of New South Wales. We also have, as part of the panel, Jess Kaza, who's a professor of biostatistics at Monash University here in Melbourne, as well as Professor Sandra Peake, who's an intensivist, trialist, and professor at the University of Adelaide, and also Chris Seymour is an intensivist researcher and associate editor for critical care at JAMA. So please welcome our panel. Just a reminder about the hashtags for this session, which will be hashtag CCR Down Under and hashtag ImmunoSep trial. We will have time for questions after the editorial, and we'll be able to take those from here in the in-house, and also via the live stream chat function, and also via social media. So just to remind everybody of the format, we'll have the trial results presented from Evangelos, an editorial then provided from Sarah, a brief reply to the editorial, questions then, and then a panel discussion, which will then finish up after that. So with no further ado, I'll welcome Evangelos to give us the trial results for ImmunoSep.
Well, I would like to thank you very much for this elegant invitation. It is a great honor for us, all the investigators of ImmunoSep, to be here. And without further ado, I would like to make you known that this is an honor which does not belong only to me. It belongs to Professor Mihai Netea, who is the coordinator of the ImmunoSep grant and who is a real visionary. I had the honor to meet him 20 years ago in the Netherlands, and since then we're working together, and we bring these results to you today here. Actually, I would like to let you know that this trial was sponsored by the Hellenic Institute for the Study of Sepsis. It was funded by the EU. And actually, we are an institute which is non-commercial, academic, and we are devoted to precision medicine. With that approach, during the pandemic, we registered in Europe and in America an anakinra driven by biomarkers for the management of severe pneumonia. And as you may see, we have a long track record having to do with publications, PhDs, and also guidelines, international conferences. We have, of course, an organizational chart without which it's impossible to reach a trial like that, having to do not only with quality control and project management, but also with a lot of CRAs, pharmacovigilance, clinical physicians, and also computational department. This is a marathon which started in February 2020 in Nijmegen, after we got granted by the EU. And the marathon, which is something very known to my country. I come, as you know, from Greece, and the traditional marathon route is near actually my home. And we know that it's pretty difficult. It's pretty difficult because it's always with hills, climbs, and a lot of difficult angles to handle with. So many people, they start from the traditional village of marathon, and meanwhile many of them get tired, they give up, and always it is a struggle to reach the finish at the center of Athens. And this marathon for us started before the pandemic with a small phase 2A trial which was funded by leftovers of grant by Professor Netea and myself, showing that patients at septic shock, they may be classified by using biomarkers in 3 different strata. The worst outcome is the stratum which you see in red. These are patients with macrophage activation-like syndrome. Almost 80% of them die by day 24. And then above that, you have the blue stratum, which are patients with sepsis-induced immunoparalysis, a better prognosis, but still 60% of them, they die by day 28. And in between them are patients who immunologically are unclassified. This gave us the idea that all patients who meet the sepsis 3 definitions, they can be classified by using ferritin, but here we need to outscore the concentrations of ferritin in the blood, not just increased ferritin, but actually increases at almost 20 times more than the upper normal of limit, more than 4,420 nanograms per ml, which indicates, classifies a patient into macrophage activation-like syndrome, which is driven by L1, and there anakinra, a drug which blocks the activity of both L1 beta and L1 alpha, could be the drug of choice. And patients who have ferritin less than that, but also they have low HLA-DR. How low? Less than 5,000 receptors per the cell membrane of a monocyte, which means that there is failure of antigen presentation, failure of the activation of lymphocytes, failure of monocytes for the production of cytokines, and the only way to improve the patient is to wake up the cell. And in order to wake up the cell and reverse that thing is to stimulate that. And how to stimulate that? With recombinant human interferon gamma. So this is the trial. A trial which took place in 33 study sites in Europe, 6 countries, enrolling patients with lung infections or primary bacteremia, meeting the sepsis 3 definition, and in the attempt to start to give treatment in less than 72 hours from onset of sepsis, into 2 strata, but not strata for each of the drugs. The idea is that we want to compare strategies. The one strategy, precision immunotherapy for 15 days, and these patients, they receive standard care, but on top, every patient in this trial receives 2 interventions, one IV, one sub-Q. The patients who are in macrophage activation-like syndrome, they receive IV anakinra and sub-Q placebo. Those who are with immunoparalysis, they receive IV placebo and sub-Q recombinant interferon gamma. And the comparator group, they receive 2 dummy interventions with standard of care for 15 days. So included patients, they have either community-acquired pneumonia, ventilator-associated pneumonia, hospital-acquired pneumonia, or primary bacteremia. They are adults. Only patients with moles and sepsis-induced immunoparalysis are classified, and the patients can be enrolled provided that treatment, study drug, can start less than 72 hours from the sepsis onset. So all what I describe you, it's a type indeed of not just marathon, but actually as a race. And something unexpected. When we started that, there was no COVID-19, and all of a sudden COVID-19 came. And the question was, could we harm patients with that? And after discussions with the EMA, we ended up that if a patient with acute COVID-19 suffers from moles, he can be enrolled in the trial, but not if he has sepsis-induced immunoparalysis. And only patients who are recovering from COVID-19, they are SARS-CoV-2 negative, and they have CAP, VAP, or HAP, or BSI with immunoparalysis, they can be enrolled. Of course, when it comes to a phase 2b trial, there are a lot of exclusion criteria. The major is that we did not treat urinary tract infections. Why? Because more or less they have a good prognosis. We did not treat intra-abdominal infections. Why? Because it's the question of source control, which at that stage is something which we cannot probably adjust. And other major exclusion criteria was that patients should not be on chronic treatment with anti-cytokine drug, and they should not be on chronic treatment with corticosteroids. So, this is the screening. This is the map of Europe, all the study sites, and most of patients, they come from my country, Greece, and in order to do this, you need to screen continuously, sleepless, because it's not only the transportation of samples. Over follow-up, you need to monitor the patient. In exactly the same way, the central lab should be ready for that monitoring. The primary endpoint. So the primary endpoint was not for us any more mortality. after the sepsis redefinition, this is what came to our mind, we have a measure of organ dysfunctions. And if you want to improve the patient, you need to improve organ dysfunction. And in collaboration with the group of YINA, they have developed the last 15 years the idea that what is important is the change of the mean SOFA score. What does that mean? That means that you need to calculate the mean of all SOFA values from day 2 to day 9. Day 1 is the day of the start of the study drug. And then you subtract that mean from the SOFA score of day 1. If it goes to a decrease of more than 1 point, 4 points, the patient has reached the primary endpoint. If not, the patient did not reach the primary endpoint. And if you ask me, how do you treat patients who have died? Then you give them 24, which is the maximum a SOFA score may get. And if a patient have left the ICU earlier, then you bring the last observation forward. The secondary endpoints was actually if this change of the SOFA score could be met for both arms, macrophage activation-like syndrome and sepsis-induced immunoparalysis, if it could be prolonged until day 15, if there is an impact of 28-day and 30-day mortality, and 2 major pharmacodynamic features, but not in the traditional way pharmacodynamics are working. Is immune dysfunction restored? And how fast does that take? One thing and the other thing. In the very end, sepsis has to do with an infection. Is this immunotherapy assists the improvement of the state of the infection? And also we brought some secondary endpoints having to do with subgroup analysis of the major severity scores, APACH2, Johnson's Comorbidity Index, and SOFA score as the subgroups they impact on mortality. So, the most important thing, we had to screen 672 patients to enroll 281 to randomize. That means that we managed to classify 1 out of 2.5 patients. We still have 1.5 patients out of patients meeting the sepsis redefinitions which are unclassified. But from the patients who are randomized, we had in the precision immunotherapy arm 131 in the intent to treat population. In the comparator placebo arm, 145 in the intent to treat population. Before jumping into the results of the trial, the question is, are the 2 groups in terms of randomization similar? Do we recognize in the demographics of the patients, pragmatic patients, of our reality? Because if we do recognize patients of our reality, then this trial is of essence. So most of them are male. They are around 70. The major comorbidity is the comorbidity of our times, type 2 diabetes mellitus, but also, as you may see, a lot of cardiovascular risk, chronic heart failure, coronary heart disease, atrial fibrillation, stroke, chronic renal disease. The patients, they have an average of a patch of 20, a Johnson's Comorbidity Index around 5, a SOFA score of 10, in other terms, a SOFA score which is anticipated to bring a lot of lethality, and the majority, they're on mechanical ventilation, almost 90%. 90% they are on vasopressors, and around 20% are on CVVH. The next question is, did we treat them appropriately? Was the standard of care which we administered for the underlying infection even between the 2 groups? And as you may see, the distribution of the underlying infections, ventilator-associated pneumonia, community-acquired pneumonia, hospital-acquired pneumonia, primary bacteremia, is the same between the 2 groups, and the most common administered antibiotics were carbapenems, piptazo, colistin, linezolid, and glycopeptides. And if you ask the question, among the patients for which you had antimicrobial susceptibility testing, did the selection of antibiotics was appropriate? And it does. The ratio between administering at least one antibiotic active against the pathogen is even between the two groups, and this is of major importance. The patients, they are hypoxemic, they have high CRP, high PCT, high lactate. Around 20% are on macrophage activation-like syndrome, high ferritins, a drop of HLA-DR also in macrophage activation syndrome, which we believe is a negative feedback from the hyperinflammation, but when it comes to sepsis-induced immunoparalysis, which are the majority of the patients, ferritins are low, and indeed HLA-DR is low. Now, let's move to the essence. The primary endpoint is met, and I repeat that the primary endpoint is defined as a decrease of the average SOFA score between days 2 and 9 from baseline day 1. In what percentage is this reached? 35% of patients in the precision immunotherapy group versus 18% in the placebo group. This difference is statistically significant. The odds ratio is 2.48, and someone would say, okay, but still, this is one-way comparison. It's only a univariate. Before jumping into this, before speaking about that, let me to show you something modern, something which we like very much, particularly from systemics biology, a heat map. Each of the rows is a different patient. Patients in the placebo group are in left, patients in the precision immunotherapy group are in right. The more dark you get, the more the SOFA score is increased. When there is absolute darkness, SOFA score is 24 and the patient dies. In the red bar are achievers of the primary endpoint, in blue the non-achievers, and the more white you have, there is light. The SOFA score goes down and the patient is improved, and there is no doubt that in the precision immunotherapy arm, the SOFA scores and improvement of organ dysfunction is much more clear in the intervention group than the placebo group. But also let's go for a multivariate regression model, logistic regression model, taking into consideration, according to the statistical analysis plan, the APACH2, the Johnson's Comorbidity Index, the SOFA score, and also the heterogeneity in terms of patients which could have been enrolled between study sites. And the only variable which is missing is the only one which is in the multivariate analysis is significant, and this is allocation to precision immunotherapy, and the adjustment of the odds ratio is even better from 2.48 to 2.49. Then someone may ask, does it work both ways? Both patients with macrophage activation-like syndrome and both patients with sepsis-induced immunoparalysis, they get benefit out of this treatment? Let's see separately. So, macrophage activation-like syndrome, almost 50% with anakinra. Standard of care, 17% with placebo. Sepsis-induced immunoparalysis, 32% benefit with recombinant interferon gamma, 18% with placebo. In both cases, the difference is statistically significant. So if you choose correctly your patient, if he has macrophage activation-like syndrome and gives to the patient what he's in need of, if you choose correctly the patient has immunoparalysis and you immune stimulate, in both cases you get benefit. And someone may ask, okay, day 9, I want to see by the end of treatment, day 15, does this superiority maintain? And the answer is yes, it is maintained. and actually the same percentages, the same odds ratio until day 15. What about mortality? Actually, there is no statistically significant difference, but there is an absolute difference of 6%. Almost 50% is the mortality in the precision group, 43.5% in the precision immunotherapy group. The absolute difference is 6.1%. However, when we reached day 90, there were no actual differences. And however, what we investigators will look at the survival graph was that there is still a separation between the two groups until day 40 and day 50, and of course, and I assume that this will jump out during panel discussion whether we need to prolong treatment in the patients. Restoration of immunoparalysis, the pharmacodynamics. What does that mean? A decrease of ferritin in case of macrophage activation-like syndrome, and this benefit sustains, or more than 8,000 HLA-DR receptors on monocytes with treatment, and this sustains. And actually, I would like to present you the results as the time to restoration of immune dysfunction. And you see how faster the two curves they separate. The orange curve of precision immunotherapy versus the blue curve of placebo. There's a big gap between them, and the actual percentage of patients in the precision immunotherapy which they reach this restoration of organ dysfunction is close to 80% compared to 50% of the placebo group. And this has a huge also impact in the disposition of infection. How was this done? We gave pre-specific criteria to our investigators, and these investigators, they decided by day 15 if a patient was on white, which means resolution of infection, or green, intermediate, failure in yellow, or superinfection in blue. And the odds ratio for worse outcome was less than 1 in the precision group, which means that there was a relative 41% benefit towards better outcomes. Some subgroup analysis for the primary endpoint. We depicted cutoff of 25 for Apache 2, of 5 for Shelton's Comorbidiety Index, of 10 for SOFA score. And you see that the best achievers of the primary endpoint are those with a SOFA score 10 or more, or CCI 5 or more. And how about mortality? Against the subgroups with most of mortality benefit, which was statistically significant, were those with Apache 2 less than 25, with CCI 5 or more, and SOFA score 10 or more. Adverse events. You understand that from the very beginning, that was our prime concern. And we had such an intense surveillance and monitoring of the adversities of our patients, and we reported 1,069 treatment-emergent adverse events. The vast minority, which you may see on the left columns, were those which were probably or possibly related with the studied drug. The majority were either unrelated or not related. And there was just a trend for higher incidence of anemia in the precision group and higher incidence of hemorrhage in the precision group. With that in mind, I would like to conclude that, and I'm pretty proud and happy that we managed to bring light to the fact that if you select your patient, if you frame the endotype of your patient from the very beginning, and you give precision treatment, after 5 days of treatment, you may improve organ dysfunction. And this applies irrespective the organ dysfunction. What counts is to recognize if a patient has MALS or if a patient has sepsis-induced immunoparalysis. And from the moment you know that you deliver an anti-inflammatory drug in case of mumps, and an immunostimulating drug in case of sepsis-induced immunoparalysis. This is extended by day 15. There is a decrease, however, it's not statistically significant, on 20-day mortality. No effect on 90-day mortality. However, what counts, and it's the most important, is the intervention works. Why? Because it brings a restoration of organ dysfunction. And along with this, it brings an improvement of the outcome of the infection. When it comes to something like that, you are in need of heroes. And the heroes should be heroes of the reality. They are those who work 24/7 for one entire program, always with the smiles. They're not only the smiles for the photos, they work on a daily basis. These are our partners, and all of them we wish to thank wholeheartedly the coordinator of the ImmunoSep grant, Professor Netea. But I want to spend 3 minutes to tell you what is coming next from our consortium. Because what we are in need of is that our consortium stays alive. And staying alive means that we want to have our teachings, but we want to go one path forward. And one path forward means, out of 2.5 patients so far, we managed to recognize one. So we were in need to know what's happened in the others 1.5, and this is what is happening. By using a discovery set and a validation set, together with Massimo Antonelli and Michael Bauer, we ended up that we discovered a third endotype, which is an ambivalent pro-inflammatory endotype driven by interferon gamma. And then we said, now let's do something even more challenging. Do a phase 2A trial, which actually I'm glad to announce that for which that we have finished enrollment. 75 patients, randomized into 3 groups, receiving with sepsis driven by endotype by interferon gamma, receiving treatment either with placebo or a low dose of a monoclonal which inhibits interferon gamma and which is called emapalumab, either at low dose or at higher doses. And someone would say, and what's the novelty? Just an endotype. The novelty is not just the endotype. The novelty is the great teaching coming from the survival curves from which I spoke to you earlier about 90-day mortality. That you need to use your biomarkers not just to enroll the patient, but to decide when is the correct time to stop, taking into consideration the maximum of the efficacy and to minimize harm. With this in mind, these are the smiles of all partners around Europe of ImmunoSep in our last gathering in Kalamata 2024 when we were discussing about the data. I would like to make known that the results of ImmunoSep are online at JAMA, and I would like to, the last seconds of my talk, to open my heart and say that it took me 20 years to reach that stage. 20 years for which I'm thankful to my collaborators. I'm thankful to my parents, but most and above all, I'm thankful to my 4 children and actually my beloved wife who supported me unconditionally. Thank you very much.
Have a seat for us. Okay, thank you so much, Evangelos. Now we'll invite Sarah to deliver the editorial. Great job. Thank you.
Thank you. I'm thrilled to be here to give the editorial for ImmunoSep, as just has been beautifully presented by Evangelos. So the central question here is, in people with sepsis, can host-directed immunomodulation based on a measured immune dysfunction improve outcome? And historically, this audience knows that the treatment of sepsis has been largely supportive, combined with directed antimicrobials. And there's been moments of great excitement, particularly around the use of activated protein C in the past, which was approved by the FDA in 2001, only to be later withdrawn in 2011 for signals of inefficacy. But overall, as we can see, the field is moving away from syndromic treatment of sepsis to more personalised medicine models. And certainly the COVID-19 pandemic represents a watershed moment in medicine where immunomodulatory therapies such as dexamethasone, baricitinib, and tocilizumab were demonstrated to reduce mortality in moderate to severe disease. So current frontiers in sepsis include defining clinically relevant subsets of patients based on the type and source of infection, patient phenotype or endotypes, and the identification of these treatable traits. So this slide nicely summarizes some of our current understandings of sepsis. In the left panel, we know that people walk around with risk factors for developing sepsis, which include age, genetics, environment, medical comorbidities, and indeed their treatment. In the middle panel, the syndrome of sepsis is characterized by both a hyperinflammatory state, as shown in red, and also a compensatory hypoinflammatory state, as shown in blue. And then in the third panel, there's an increased interest in sepsis survivorship, and we know that patients who survive sepsis remain at increased risk for reinfection, readmission to hospital, and mortality over the coming months and years. And so ImmunoSep sits in that middle panel during the acute phase of sepsis, where we know excess inflammation is mediated by pro-inflammatory cytokines such as IL-1, as we'll hear about today, as well as IL-6, IL-12, TNF-alpha, and interferons. And the compensatory anti-inflammatory response is mediated by IL-10, IL-1 receptor alpha, which competes for the IL-1 binding site, and TGF-beta. And really, our colleagues in oncology have been the field leaders in precision medicine. And increasingly, patients with the same type of cancer are not being offered identical therapies, as shown in the top panel. And that's because if you take the same group of patients and give them the same treatment, some will benefit, some will have no benefit, and some will actually cause harm. And so now increasingly, malignant tumours at diagnosis are biopsied and undergo assessment of genetic mutations such as BRAF in melanoma, assessment for hormone receptors such as HER2 in breast cancer, tyrosine kinases, and immune checkpoint inhibitors such as PD-L1 in melanoma, lung, and renal cancer. And based on the results of those tests, individual patients are offered tailored treatment programs. And so in the bottom panel, we see on these tailored treatment programs, the overall aim is that more patients will have a favorable outcome to treatment. And so the lesson here is that similar principles can be adopted in the management of sepsis. And so it's within this history that ImmunoSep stands. This is a landmark trial of immunomodulation in sepsis. As Evangelos explained, on the left side, adults with sepsis due to CAP, HAP, VAP, and bacteremia was screened. They had serum ferritin measures levels, and if the ferritin was high, greater than 4,420, they were classified as hyperinflammatory with MALS, macrophage activation-like syndrome. If the ferritin was low, less than 4,420, and there was downregulation of HLA-DR on the monocytes, they were classified as hypoinflammatory, or SII, with sepsis-induced immunoparalysis. Important to note that middle panel in the yellow box, these patients were unclassified. They had low ferritin, but the HLA expression on the monocytes were retained, and this proportion of patients were excluded from the trial. So this is a trial that studies the extremes of hyperinflammatory and hypoinflammatory sepsis, and the primary endpoint, as we heard, was a decrease in SOFA score by day 9. But the top arm, the hyperinflammatory, were randomized 1-to-1 to anakinra, the anti-IL-1 agent, or placebo, and standard of care, and the hypoinflammatory patients were randomized 1-to-1 to recombinant interferon gamma, or placebo. Another strength of the study was it was conducted across 33 sites in 6 European countries. So this is a randomized, double-blind, double-dummy, placebo-controlled trial All patients received an IV injection every 8 hours, whether that be anakinra or dummy, and a subcutaneous injection every 48 hours, being interferon gamma or dummy, for 15 days. Personalized immunotherapy. There was a decrease in SOFA scores noted at day 7, but the effect was lost when treatment was ceased. So my first question to the trialists were there any other therapies considered for the hyperinflammatory patients, such as anti-TNF-alpha, anti-IL-6, anti-IL-12 or JAK inhibitors? And similarly, I understand interferon gamma was used for the hypoinflammatory group based on part by Doc et al.'s report in Nature Medicine, and I was interested to know whether any other agents were discussed. The measurement of HLA-DR molecules on the monocytes is appropriately rigorous. It involved taking peripheral blood samples, staining the monocytes with monoclonal antibodies to monocytic markers, and the antibody has a fluorochrome bound to it. The mean fluorescence intensity of that fluorochrome was then read against a standard curve, which plots the mean fluorescence intensity against a known quanta of molecules. So this is an excellent and a robust measurement for the purpose of a clinical trial, but it may be prohibitively complicated or expensive for a public hospital diagnostic lab. So another question was, would there be a more simplified measurement that could be used, such as percentage of monocytes that are HLA-DR positive, setting a cutoff around the standard deviation of the mean, as that's something that's used for CD20 reporting in B-cell malignancies around the prescription of rituximab. The primary endpoint was reached in 35.1% of the interventional group and 17.9% in the placebo group, leading to an odds ratio overall for all patients of 2.49, a number needed to treat of 6, and number needed to harm of 200. But it's important to look at the overall percentages. So if we look at the number of patients screened and use 672 as the denominator, of the patients classified as males, it was only 7% of the screened group. The SIR group was 34%, but just for noting that unclassified group is actually the majority of patients at 59%, so they were excluded from the study. Additionally, if you look at the study design, it's essentially 2 randomized control trials run in parallel. And for discussion, could the statistical analysis have been done for the 2 RCTs separately? And a question for the statisticians, what are the implications for analysing the combined precision immunotherapy group, as shown in red, together, and the combined control groups together? The secondary endpoints, a number of them were also reached, including a decrease in SOFA score by day 15, which was higher in the interventional group and the placebo group, and that was achieved in both the anakinra and the interferon gamma-treated groups. Also, the reversal of sepsis immune dysfunction, which is a drop in the ferritin and a rise in the HLA-DR expression, was also achieved higher in the interventional group. And looking at whether there was a signal for harm with the intervention, the odds for worse infection outcome by day 15 was actually lower in the interventional group, which is reassuring. So this slide is just to say that the reports of this trial are not a single anomalous significant result, but actually of the biomarkers and secondary endpoints measured, the results are highly concordant and all appear to favour the intervention. Other features for discussion: the study was run during the COVID-19 pandemic between 2021 and 2024, but I was interested that only 4 patients were enrolled with COVID and all in the hyperinflammatory group. And in fact, the methodology states that they were only eligible to enroll in the hyperinflammatory state and not in the other group, and I was interested to understand more about that decision. Additionally, I'm interested in how a decrease of 1.4 in the SOFA score by day 9 relates to more traditional clinical endpoints such as ICU and hospital length of stay, days alive free of organ survival and death. I do note there was no difference in the 28-day or 90-day mortality, but acknowledge that the study was not powered to demonstrate statistically significant effect on that. There were 13 serious adverse reactions and no major indication these were overrepresented in the intervention. So there are 2 in anakinra, 2 in the interferon gamma group, and 4 in the placebo group. In the anakinra group, there was an increased rate of anemia, Anakinra is most widely used for rheumatoid arthritis and a very rare pediatric condition called NOMAD, and is associated with injection site reactions, allergic reactions, and increased rate of infection. So the signal around anemia is somewhat unexpected. In the interferon gamma, we saw increased rates of hemorrhage with thromboembolism, elevated creatinine, and GGT. So interferon gamma is licensed for chronic granulomatous disease and severe malignant osteopetrosis, and has been associated with the raised LFTs, as we saw, as well as injection site reactions and mild cytopenias. But just for flagging, interferon gamma is not a drug in wide clinical use, and I believe there would be far less post-marketing safety data on interferon gamma as compared to anakinra, which we're much more familiar with. In summary, ImmunoSep is a landmark trial in the field of immunomodulation in sepsis. A strength is that it uses relatively available measures to classify adult sepsis patients as hyperinflammatory or hypoinflammatory. Within these subtypes, patients were successfully randomized to a relevant immunomodulator, and the primary endpoint of the drop in SOFA score by 1.4 by day 9 has been demonstrated to be a surrogate marker for clinical outcomes in other trials, such as VSEP and MAXEP. And the differences between the groups were still evident at day 15. So in conclusion, the results of this phase 2b study warrant further investigation in larger clinical trials. A question both for the trialists and the panel is, what is the correct trial design for the phase 3 trial? Should the two interventions continue to be analysed in combination, or should they be separated out? And what are the estimated power calculations? Can we improve our understanding of those unclassifiable patients to try and include the missing 59% of patients in future work? But overall, a larger multi-centre RCT will allow for increased statistical power, and I think we need to be open-minded to the fact that an intervention in one of the arms, either hyperinflammatory or hypoinflammatory, there may be greater efficacy compared to the other. And I also wondered whether consideration of adaptive platform trial could be useful to allow the assessment of multiple therapeutics efficiently, and I think that could be of value. But overall, sincere congratulations to the trialists.
So actually, I would like to thank you very much for appraising us. I have to admit that I was afraid for the worst, which did not come, and thank you so much for this. So indeed, you pointed some very crucial facts, which are always the issues that are bothering us in the consortium. And I would like to, I could not keep notes, but I would like to go through one by each of them regarding, I would like to start from the end, about your comment on the pivotal trial. As a matter of fact, I cannot disclose details, but what I can disclose is that the consortium has asked a meeting by the ETF of the European Medicines Agency. ETF stands for Emergency Committee, and we will discuss what there are suggestions for a pivotal trial. I believe that the suggestions for a pivotal trial should directly come from the regulatory and should not remain only at the opinion of the investigators. So we will bring the issue to them, and it's up to them to decide whether they want to keep the design like that or to have two independent trials. That's one thing. The second thing which you said with COVID. At the time when the pandemic came, one of the major features was COVID was already known and acknowledged to be a state of cytokine storm. By giving treatment and by randomizing patients, particularly in the recombinant interferon arm, could we further harm them? Could we further introduce cytokine storm? At that point, at the beginning of the pandemic, we had a publication at Cell Host and Microbe suggesting that if you add in the culture media of PBMCs of patients with COVID-19 recombinant interferon gamma, you get a burst, an explosion of cytokines. So this led us to say that at least for the time being, we cannot do that. Regarding your questions and your comments about safety, honestly speaking, I was really afraid about particularly the skin side effects of the injection of the drugs. And actually, when we had the registration trial of anakinra during the pandemic, again at that time anakinra was not given IV, it was given sub-Q, but yet we did not have any skin reactions. And this led us to consider that with these drugs, you get skin reactions only when there is no vasodilation coming from infection. You need an integrity of the vascular endothelium in order to get skin reactions. About what you said for 2 trials, it may well be the case that originally it should have been designed as 2 different trials, but in our minds, what prevailed is that what counts is the strategy. To bring the proof that if you follow a precision strategy, you may improve the outcome of your patient. And finally, about the selection of the drugs and what happens with patients who are in between. Regarding the selection of anakinra, I'm fully confident that it is the only drug which can be used for patients with macrophage activation-like syndrome. Why? Because we know that this is stimulated by excess production of IL-1. There are also, in patients who are in between and who could not be classified in a way that they could be randomized in the ImmunoSep trial, other patients at pro-inflammatory sepsis. Probably these are the patients for the anti-IL-6 or the anti-TNF which you suggested. And regarding the immunostimulation, the reason why we selected Immunokin, this is a trade name for recombinant interferon gamma, was because that was tested in healthy volunteers at Radboud in the ICU of Peter Pickers, and also it was in the seminal trial of Döke, which was published, as you already mentioned, in Nature Medicine almost 30 years ago. But it may well be the case that other immunostimulants, or even PD inhibitors, they may bring the effect in patients with sepsis-induced immunoparalysis. So in conclusion, I would like to thank you wholeheartedly for appraising our trials. I want to reassure you that all of us, we are very much enthusiastic in moving forward, but not to have the enthusiasm blurring our minds, blurring our vision, because what is the difference between success and failure in these patients is really a very short window. And we need to be very skeptical, but also with the willingness to move forward to bring light in the life of these patients. Thank you very much.
All right, well, fantastic. Thank you so much for an amazing results presentation and for the editorial, Sarah. Okay, we'll get into the meat of this discussion. So we'll actually open it up, first of all, to questions from the floor. If you want to just raise your hand, we have some microphones if anyone wants to ask a question. So Danny, just there, thanks. Maybe try switching it on. Is it? Great.
That's the clue. Evangelos, fantastic presentation and a real step forward in the management of precision medicine and critical care. I might have missed it, but I was interested in what dose you used in terms of the 2 therapies, and whether, although it was already a complex trial, would you consider targeting the dose to the resolution of the biomarkers in a more personalized dose? That was if I'm allowed 2 questions. And then the second one is about that middle group that's unclassified. As we're starting with 2 groups, that's probably relatively sort of simple. And how do we get to further groups? So have you got other biomarkers? IL-18 springs to mind that might enrich your indeterminate group into maybe a MAS type phenotype?
Well, thank you so much for these 2 very important questions. Regarding the first one having to do with the dosing. The dose of anakinra was IV, as I mentioned. It was 200 milligrams 3 times daily for 15 days in a row. And for recombinant interferon gamma, It was sub-Q, 100 micrograms every 48 hours for a total of 15 days. That means the maximum a patient could get was 8 doses. Honestly, after looking at the data, and particularly the survival data, I'm fully persuaded that we need a future where we use the biomarkers not just to start treatment, but also to surrogate treatment and to decide when is the correct time to stop. And actually, as you elaborated, and thank you very much for that, a major concern is that, and thank you very much for appraising that this is the first time this is done, but still one major concern is what's going on with the 59% patients who are in between. From the moment we came across that, our idea was how, by using biomarkers, we can classify these patients. For this, we were in need of completely new cohorts and independent cohorts, and this brought me into discussions with Massimo Antonelli and with Michael Bauer, and we brought in total 5,503 patients together, split into a discovery set and a validation set. And there we tried, and we used, actually, we were lucky because always a luck is needed in types like that, and always it goes back to what you previously said about the oncology paradigm. It seems that the oncologists, they're always one step ahead of us, and probably we need to very much carefully look at them. And the oncologists, what they suggest is that there is one prototype cancer for them, which is actually lung cancer, and this is the main cancer for which immunotherapy comes from. And they actually suggest that around lung cancer there is an infiltration, a rich infiltration by neutrophils. And the neutrophils, they hyperproduce interferon gamma, which leads from alveolar macrophages the production of CXCL9. CXCL9 is a type, I would dare to call it, and apologize me if I'm wrong, this is my interpretation, a type of innate anti-neoplastic effect. In other terms, CXCL9 destroys cancer cells. So this gave to Massimo Antonelli and to Michael Bauer and myself the idea, what happens if there is ectopic production of CXCL9 in the absence of tumor? This will destroy tissue. And we worked on this, and this is how we discovered this intermediate endotype, which still does not cover all the patients, but yet it is another 20% of the patients where there is high interferon gamma linked with high CXCL9, and this gave us also the idea for the phase 2 trial with the blockade of interferon gamma.
Thank you very much. All right, so just some more questions from the floor. Just in the front there, John.
Thank you very much. Congratulations on this important work. And I think this is, in many ways, a landmark trial in intensive care medicine. And I think the comments about extrapolating from our oncological colleagues is very important, because there's a whole different approach to treatment, particularly when you're dealing with high mortality cancers, where there's a short-term benefit and basing the outcomes on surrogate endpoints like we have here. I guess that listening to this presentation, and I haven't read the paper, I was trying to work out, is this a phase 2 trial, a phase 2B trial, or a phase 3 trial? Because what we've got here is a syndromic approach to classify hyper and hypo-inflammatory states. And although Sarah called them robust diagnostics, I'm not quite sure they're that robust at the coalface for the reasons you mentioned. I think we've got to be careful that we don't attribute too much confidence in the distinction between hyper and hypo-inflammatory states based on the variables that you have used to define that. It's important work, but I think it's going to evolve over time. And the second thing I was thinking about was the actual the drug you used, the anakinra, which to my knowledge, and I could be wrong, this is largely an off-label use of the drug, or a developing indication for the drug, and the dosing that you used was very important in terms of getting a response. And I think using anakinra in this context on a syndromal basis to define the optimal dose is really important work. And I think that's the key message, that you got that. And the fact that you got a change in a non-patient-centered outcome measure is important. But I think as clinicians, we have to be very wary about how robust that outcome measure is in terms of how a patient feels, functions, and survives at the end. SOFA is always going to be a problematic outcome measure because it's not normally distributed. It covers a number of domains with some intervention bias, which may determine that. So I guess the questions that I have is, how would you classify the study moving forward? And I recognize and appreciate and I respect this is going to be further work, an iterative process of new work to inform us. How would you classify this trial as a phase 2 or phase 3 trial? And what insights have you got in terms of further modifying or improving the diagnostics of the hyper and hypo-inflammatory states?
Well, thank you so much for these questions. Actually, this is a phase 2b trial. It's not a phase 3 trial. And why we call that a phase 2b trial? Because there were preceding phase 2a trials for the dose of anakinra and for the dose of recombinant human interferon gamma. And actually, regarding your comment on the diagnostics, ferritin is a diagnostic, is a almost point of care, based also on your commentary regarding HLA-DR. QuantiBright, this is the name of the reagent developed by BD, is the only one so far which has a CIVD mark for immunosuppression. And that's the reason why it was used in the trial. But exactly as you mentioned, in order to move forward and in order to do something robust, something which has a universal acceptance, and it's not only a first and landmark step. This is why all of us who are in the consortium, we wish to get feedback by the European regulatory authorities. Why the European regulatory authorities? Because these are the authorities to which we report as citizens of Europe. The authority is called EMA-ETF. This is the Emergency Task Force of the European Medicines Agency, and we will seek from advice by them in order to give us guidance on what can be conceived as a robust diagnostic and how to proceed to the pivotal phase 3 trial.
Thank you very much. We might just see if there's anything online. Any questions online at the moment? Emma?
Yeah, there's a lot of chat online, which is great. So we're just interested to know a little bit about the double dummy design. It's not easy at site level, so can you just explain how that worked operationally and what worked in practice and what the challenges were at the site level?
Well, you're absolutely right. This is quite a challenge, which means in order to make this moving, you are in need to train your investigators, to have surveillance, to have monitors, both unblinded monitors for the unblinded investigators, blinded monitors for the blinded investigators, and you are in need to reach that level of a 24/7 basis. Actually, what I want to offer, because you mentioned that to the discussion, is that this trial has been inspected. It has been inspected both in-house, that means the operational office, but also in sites, and no critical findings were reported. So this is a level of proof of the quality of the trial.
Okay, any more questions there? Anyone up the back?
Bala has a question.
No, up the back this time. Wait. Yep, thank you.
Hi there. Thanks very much. Excellent presentation and great trial. I would like to know if you have data on the cause-specific mortality, and in particular, if you know what the people who died between day 28 and day 90 died from, because on the face of things, it looks like there's a marked excess of mortality in the intervention group in that time period.
Well, thank you very much for that question. according to our pharmacovigilance, which was surveying that, there were no differences in the causality of mortality between the two groups. Many of them, they developed secondary infections after day 60, and that was the main reason for death.
Okay, and then I think we're back to the front now there. I think Bala.
Thank you both for fantastic presentations. A couple of questions. I think one of the points raised by Sarah was, did you find any signals in this phase 2b trial in terms of any patient-centered outcomes? I know you talked about mortality, which evened out by day 90, in terms of days alive and out of ICU or hospital, to inform a phase 3. That's the first question. And the second question is in terms of concomitant treatments, was the open label use of corticosteroids, was that similar in both groups? Patients with pneumonia generally are getting treated with corticosteroids these days. And if patients with the macrophage activation syndrome, there's people prefer to use high-dose dexamethasone or etoposide. Were those treatments evenly balanced between the two groups?
Well, thank you so much. To start with the second question, almost 50% of each group, they were on low-dose hydrocortisone as a replacement for septic shock, and another 15% of each group were on dexamethasone. There was no difference between the two groups regarding the use of corticosteroids. This is also part of the supplement of the publication. Regarding your question about other outcomes like a length of stay or length in the ICU or a length in hospital, these are data which we have. These are data which we will present when we will seek advice by the ETF. Now they are not at the level of the presentation because they were not part of the statistical analysis plan.
All right, thank you very much. Some great questions there and some great discussion. Why don't we turn to the panel now? So, Jess, I might bring you in as our sitting statistician and see if you've got any comments around some of the questions in particular related to whether the interventions should have been separated, what that would mean. Be interested in your choice, your thoughts on how the primary outcome was handled, those sort of things.
All right, well, thanks. Thanks, Evangelos. It was really wonderful to hear about this trial. So I suppose when I was reading through this paper, I had a lot of questions about the primary outcome that was selected. So we've got a continuous outcome that we're looking at a change from baseline, and then we're dichotomizing that. So, of course, dichotomization, we lose a fair bit of information about what's going on, and a change from baseline is difficult to interpret. Perhaps when analysing a change from baseline, it's preferable to adjust for the baseline measure in the analysis of that change, just because you're making very strong assumptions about the relationship between the baseline measure and then the follow-up. And of course, we're averaging over a bunch of measures. So a lot of assumptions have gone into this. And I'm just wondering about your process for coming to that choice of the outcome, this quite highly processed surrogate outcome.
Well, thank you very much for that. Actually, I will reply in a very direct way in all these comments. I just want to stress from the very beginning that exactly the same queries were addressed by the reviewers, and we have addressed them in our replies to the reviewers. However, they are not in the supplement of the publication because they do not make part of the statistical analysis plan. So regarding your first question, which is actually the relative change of the SOFA score and the adjustment to baseline SOFA score. So there is a test which is called the Welsh test, and based on that test, we adjusted for that, and the statistical significance remains, and actually the p-value is exactly the same. Also, in the supplement, in exactly the same way as I presented the heat map with the SOFA score, I present the heat map of the relative changes of the SOFA score. And the picture which you get turning from very dark, the patients who get deteriorated, to very white, the patients who are improved. The idea is exactly the same. And the third question, whether it is important, because if it has to be important, it needs to surrogate death. So the death rate among patients who did not achieve the endpoint was 59%. Among those who reached the endpoint, it was only 11%. And that, you can understand, the p-value, actually, I still remember that, 10 to the minus 9.
Very small indeed. I can certainly understand all of the points that you're making there. I guess my view is that, I mean, here, of course, we're not going to reanalyze this study. We're here to understand the assumptions that have gone into it and the limitations of it, of which there may be few. I suppose my thoughts are that if an alternative analysis approach was taken, you may have strengthened your results even further. I don't think that any of these issues would have necessarily led to a change in conclusions. But it's just interesting to think about the potential impact of these assumptions. So thank you.
Thanks very much. I mean, I think I think probably a lot of people have some uncertainty or anxiety about the primary endpoint because it's not necessarily, that patient-centered from the point of view. The change in SOFA score obviously describes a change in physiology, and so, and I think Jess's points around it being very processed in terms of an outcome, I think also, probably cause people a little moment of pause to think about what does this really mean. Yeah. So, Sandra, what were your thoughts on the primary outcome, and also maybe you want to talk about the.
May I add a comment here?
Oh yeah, of course, please.
Actually, what we believe that is necessary to do, particularly since we want to seek advice from the European regulatory, is to reanalyze by SOFA-2, because this is the future, this is the new score, and I strongly believe that all new trials to be designed and all new outcomes, they need to integrate SOFA-2. Sorry to interrupt.
No, of course. Thank you very much. Yeah, Sandy.
Can I just have a follow-up question or
By all
comment
means.
around the timing of the primary outcome? I understand all the issues around using the SOFA per se, but the intervention was delivered for 15 days, and I just wonder why you chose to use a primary outcome at day 9. So in other words, the outcome of the intervention was determined before the intervention had actually been completed. And, whilst the patients may be quite nicely in the beginning delineated into hyper and hypoinflammatory, it's not actually a fixed state, and it's potentially fluid, and patients can change from one to the other. And whether there is the potential, for example, that a patient who is hyperinflammatory and you're collecting the outcome at day 9, but then your ongoing treatment continues when the patient might have changed their immune status.
Well, thank you very much for that comment. This goes back to the way by which we granted the support of the EU, because all the financial support is coming from the Horizon 2020 grant of the EU. The idea is that you need to design the trial, present all methodological details, including the analysis, when you submit the grant. And at that point, all the consortium, we came together, and it was the time when the YINA group with senior author Frank Brunkhorst, they have just published the VSEP trial, which was then followed by the MAXEP trial. The VSEP was published in the New England, the MAXEP at JAMA, and there they introduced the change of the mean SOFA score as an endpoint, and they ended up that day 9 was the best performer in terms of outcome. So it appears probably a bit naive, but that was our sheer motivation, which was based on the experience coming from 2 big trials, but published into great journals.
Can I ask another
Yeah,
question?
please do.
I was thinking about discussions around the fact that over 50% of the patients were not able to be classified, and then going forward and doing phase 3 trials. And I was really thinking about the practicalities of designing a phase 3 trial in terms of recruitment rate. I've done a couple of sepsis trials, and it takes a long time to recruit the appropriate sample size. And so whilst we all acknowledge that going forward, prognostic enrichment and classifying patients is the way forward, by doing that, the potential patient pool is actually getting smaller and smaller, which means that your recruitment rate is actually going to be longer and longer to find those patients. And how feasible is it going forward to have the appropriate identifying biomarkers in order to get as many patients as possible with sepsis into the trial?
Well, thank you very much. And actually, what you said and what you described is the real essence. Because in order to move that to a pivotal trial, a phase 3 trial, what will be on the phase 3 trial will be the reality from the moment this is approved for market position. And there, the first question is, and allow me to open a brief parenthesis here. When I narrate to my medical students, I'm saying that now I'm almost 30 years practicing medicine, and I've never seen anything nice happening in the morning. I've seen all sepsis, all infarcts, all embolism during nights. So that means that you're in need of investigators who are willing to enroll patients at night and not at morning, which means that there is a need of a universal belief in the principle and then of a universal effort to reach that. But again, how feasible is to do transcriptomics? How feasible is to do a biomarker which is not available everywhere? How feasible is to do flow cytometry? So it may well be the case that we need to elaborate a proxy which can be physiometrics, a proxy which could be easily point-of-care biomarkers or existing point-of-care biomarkers which are not included so far. So all you said are the real problems, how you move from something like that to the everyday reality, because a phase 3 program needs to narrate the reality which will be introduced from the moment there are positive results of a phase 3 trial. And also another issue is, will the regulatories, because we address to the European regulatories, but it's not only Europe in the world. There is the American regulatory, which is of top importance, and then are the other regulators in the world. Will they accept the change of the SOFA score as the endpoint, or will they stick on mortality? That's why I believe that it's very important that we reanalyze for SOFA 2, because I strongly believe that SOFA 2 is much more functional, it's much more flexible, it's much more up to the reality of our patients. And it may well be the case that the regulatory will be persuaded to give us, instead of mortality, the change of SOFA 2 as an endpoint for registration of drugs.
Thank you very much. All right, well, Chris, someone who's very interested in precision medicine and sepsis, I guess really interested in your take on this. We've got a signal towards a significant improvement in a surrogate outcome so far, but we don't have much in terms of patient-centered outcomes, particularly in terms of mortality at 28 days or 90 days. So how do we take this forward? How do we interpret that? Interested in your thoughts.
Sure. So there's a lot to discuss, but first of all, congratulations to Evangelos and the entire team. We've been waiting for this trial for some time, and I think John's right. In a way, it is a bit of a landmark accomplishment to just pull this off in terms of a multi-center international design in which HLA-DR is measured at a central lab on all these patients. Depending on your background, if you're an epidemiologist, I'm looking around the room, there's folks that have done trials on 10,000 patients or more, there's translational scientists, there's folks that could pick apart almost every aspect of what was done. And I think that's what's exciting, both for us at the Journal, but also as someone in this space, because there's, we think, a lot of future opportunity. My mind first goes to the ferritin bit. You know, is this the HER2 of sepsis? And I don't think it is, actually. You know, this is a value that's going to change over time. It's an acute phase reactant. It can be high for multiple reasons. And the folks who spend a lot of time maybe thinking about subtypes could say, maybe these thresholds or these biomarkers weren't the right choice and you guys just got lucky. The next step then is to say, well, who cares? You know, if that's what worked, then let's do that for our patients. Others may feel like there's many layers of markers and ways to classify patients that could find an even better response. Very cool trial, and we're very excited to see this at JAMA. Derek has a fantastic editorial that's also online, a promo for that, to check out his views. So congratulations again.
You know, thanks very much, Chris. And you know, I think absolutely right in terms of the the endeavour here is phenomenal, right? To actually get this done and to make it happen, and to and certainly this concept of precision medicine and being able to tailor therapies to biomarkers, you know, is certainly, as we've already suggested, something the oncology team, you know, guys have been doing for a very long time. And so it's great to see this being, you know, translated into intensive care medicine. Just in terms of the thresholds, where did they come from? The ferritin, particular thresholds for ferritin, you know, is that based on, you know, observational data from your team or other trials, or just interested in that?
So someone could immediately say, I don't have a patient with a ferritin of 4,000. I have a patient with a ferritin of 3,000. Can we indeed present ourselves and claim that the patient is not suffering from hyperinflammation? So immediately, your question holds true. So in other terms, before jumping into the phase 2A PROVIDE trial, as you mentioned earlier, we had to identify a cutoff of ferritin. And because what we have in our mind was to go for a trial, we wanted a cutoff which could give, if possible, a specificity of 100%. So in other terms, from the moment we enroll a patient, we are certain that this is a patient who has macrophage activation-like syndrome. We may miss other patients with macrophage-like syndrome or mimicking hyperinflammation, but in order to be certain, in order not to harm, we had to raise the bar. So actually, what I can tell you is that this cutoff provides a 98% specificity, 97.1% negative predictive value. And actually, from the moment you presented your data in 2022 from the Adrenos trial showing that you found a similar prevalence of macrophage activation syndrome in US, the Adrenco trial. Well, he's the first author at least. And as far as I know, Professor Angus is the senior author. The prevalence is exactly the same as we found in Europe. And from the moment we have seen that, our belief about the use of ferritin, because also you described that cutoff of ferritin there, was extremely strengthened.
Yeah. I think some people would say, well, if MALDS is only present in 8% of the population, is it really worth us going after this? And after this trial, I'm kind of thinking we should probably not minimize the potential to treat that subgroup. Sandy's point about how the immune state changes over time, I think is very relevant. That's obviously a hard one to handle inside an RCT. But there are folks that are thinking about continuous ways of measuring the immune state of the patient. Manu and his colleagues, the folks in Amsterdam who have come up with a dysregulated immune profile, which is a continuous measure of one's immune state. I think there's a lot of opportunities to think about how that could be incorporated into a trial design so that you're not potentially, you know, on the wrong side of the curve, so to speak.
I think that is the way to go, that you monitor the immune status over time and you truly individualise treatment by addressing it on a I don't know whether it's a daily, 2 daily, or whatever basis, to modify according to what the patient's immune status is at that point of time. Because otherwise, to me, it seems a little bit blunderbuss just to say that here's this patient on day 1 or day 2, and I'm going to give them 15 days of treatment, and it ignores everything that's happening over that subsequent sort of 2 weeks.
Food for thought. So I guess the one thing there, though, is 15 days. Why was it 15 days? What was the decision around 15 days of treatment?
Well, again, thank you for that. Probably this is another limitation. Why not to give longer? And as you mentioned earlier, it was really painful to see that there was improvement in the phase 2A trial when treatment lasted for 7 days. Until day 7, patients were experiencing improvement, and from the moment treatment was stopped, on day 8, that benefit was vanished. Not decreased, vanished. And this gave us the idea that probably we need to prolong at least another 7 days. It's a phase 2A trial, exactly as you mentioned, it was mentioned earlier, that you need to gate decisions, many of which may even be arbitrary.
I think that's going to be relevant.
No.
Just enrichment in general, I think is something to reflect on as folks get into the paper and sort of read about the design. Just as many folks in the room are planning new trials with procalcitonin or what may be, those margins are never black and white. They're always fuzzy, and yet the pragmatics of pulling off the trial make there quite a bit of tension around those decisions.
Yeah, cut points are always a topical point. Just about the 15 days, practically though, presumably was this intervention delivered once the patients were discharged to the ward or only whilst they were in ICU? So what was the average duration of treatment that the patients actually did get?
Well, it was similar to the rationale which drove to the disposition of the infection by day 15. Those who were brought together in this ImmunoSep consortium, we are both ICU and ID physicians, and we are running both ICU and ID trials. So in the field of infectious diseases, things are not that, let's say, robust, in quotation marks, as it's happening in the ICU. In infectious diseases, at a certain time point, an independent party comes and gives the impression, how is the outcome of the infection? Is this improved? Is this resolved? Is this cured? Was there a superinfection? So, and always when it comes to infectious diseases, this needs to be done at the test of cure visit or the end of treatment, if the end of treatment is prolonged so far, so that it's reaching 15 days. So, in the very end, sepsis means not just to improve organ dysfunction, but also means that you improve the functionality of the immune system to eradicate the improved infection. So this is how we tried to bring these two together.
All right, why don't we go back to the audience? If we have any other questions, a lot of hands gone up there. So just over here, yes, thank you.
Thank you. Great presentation. I was wondering if you had more information to share about the distribution of the changes in SOFA score. Were they sort of distributed equally across the 6 components of SOFA, or did you see a dominant theme? And particularly, did that vary depending on whether they had, super active inflammation or the immunosuppressed part of the trial?
Well, thank you so much about that. Regarding the baseline demographics, and you may read that in our table of demographics, the individual scores for each of the component of the SOFA were even between the 2 groups. And when it comes to your question, if we get the relative change of each of the components of the SOFA score, and we compare through an ordinal regression model each between the 2 groups for each of the relative changes, most of the benefit has to do with the coagulation and renal function and vasopressors. However, these are not presented because they do not make part of the statistical analysis plan.
Right, next question there. Yeah, Belinda.
Sorry.
Yep, you're on.
It's on, great. I've got two questions. Thanks to Paul for asking one. The other one was around early intervention, because we all sort of say in sepsis that early intervention is what makes all the difference. And we've seen lots of studies done where they've said, no difference, but you were too late. You know, you should have done that a lot earlier. So I'm just wondering about your 72-hour time frame. And within that 72 hours, at what time did the intervention get applied, assuming that they were randomised within that 72 hours? And if you're doing the next study or research in the future, and understanding the logistics of screening, consent, and then doing biomarkers, etc., is there potential to decrease that 72 hours? Because I noticed that you, in your consult flow diagram, you lost very few patients to outside the time frame.
Well, thank you for this. The average delay from the onset of sepsis until the start of the study drug was between 48 and 50 hours, and that was even in the two groups of treatment. What do you say about if we could make this shorter? Much has to do with the logistic of the trial, and also much has to do with the complexity of the biomarker. The only way to make this faster is to try to avoid flow cytometry, because flow cytometry takes time. It requires the transportation of the sample to a place where there is expertise, and this prolongs the duration until the decision to enroll a patient or not. If we manage to substitute that with a point of care which can bring information for sepsis-induced immunoparalysis, even to the information which we have from QuantiBrite, then I believe that we can indeed make this faster.
Right, and we've got some questions online, I think.
Conveniently, we do. We're just wondering about the implications for clinical practice from this trial.
Well, thank you very much. This is probably the $1 billion or even more dollar question. And why this? The question is not the implications for clinical practice. The real question is how much us physicians, for some of our patients, we are able to change the way we think so far and to get trust from the biomarkers, trust of the endotyping, and delivering treatment because a biomarker is increased or because a biomarker guides towards the one or the other directions. There are many drugs which have been approved by regulatories, and yet they were either abandoned by physicians or they were even retracted from the markets from the industries which were producing them. And at least in the field of infectious diseases, I can with safety speak for two drugs for the Clostridioides difficile field, just because it was difficult to implement them in the daily practice, and it was difficult to change the traditional approach as physicians we are approaching things. So it's not part of making a successful trial. It's not only a matter of persuading the regulatory, running a pivotal trial, getting the registration, but also of training everyone into a different way of approach. Those of us who are here in this conference, we are here because we like to call ourselves experts, and actually expert means someone who has the motivation of better understanding what this is about, or at least is my interpretation about the definition of what an expert is. The question is, the majority of those who are facing our patients and who are helping our patients and who are willing to give treatment, they are not in this audience. How can we motivate them? How can we implement this new mentality? This is my biggest concern.
Well, I think just to draw you out there, so I guess you're back on service on Monday next week, and you're faced with a patient who's, got a community-acquired pneumonia, mechanically ventilated on noradrenaline. Are you sending off ferritin to work out whether they've got an activated?
When I am present, my residents, they always follow my path. The question is, what will happen when I'm absent? Because this is what training is, to bring it back of their mentality from the moment they leave residency and they go to work at another place. Will they follow that paradigm?
So, sorry, are you getting the ferritin done and giving some?
Of course.
You are.
No doubt.
Okay.
And HLA-DR as well.
Okay. Sandy, are you going to be checking a ferritin Monday? And
I won't deliberately check it, but if I see a result that someone's ordered, I will look at it, yes. Whether that changes anything, that's a different question.
Right. Well, okay, I think we can probably mull on that. I think that's as has already been indicated, is the major question is the data sufficient to think about changing practice? And that's going to be something which individual clinicians are going to want to think about and consider. And why don't we do that over a coffee? So thank you. Join me with thanking the speakers and the panel. An amazing first session.
Well done. Well done.
It was a truly remarkable endeavour. And so morning tea and coffee will be served down in Zinc. Please join us down there and visit with our exhibitors. And if you can be back in the seats, please, for a 10:55 for an 11 a.m. start for the next session. Thank you very much.
The panellist, and then when I sat down and I looked.